Discover the next level of critical care expertise with the Intensive Care Nutrition Fellowship, a phenomenal program for aspiring professionals in the field. With the increasing importance of nutrition in critical care, this fellowship fills a crucial void in training. It's not just a program, it's a deep dive into advanced clinical nutrition knowledge. The fellowship covers everything from basics to advanced concepts of nutrition for adults, children, and newborns, tackling questions about various critically ill patients across different specialties. This includes medical, surgical, cardiovascular, renal, hepatic, oncological, transplant patients, and more, encompassing both enteral and parenteral nutrition. Upon finishing, attendees will be capable of confidently and securely formulating nutrition plans and managing any related complications. Join the fellowship to reshape healthcare and transform your dedication to patient care into a leadership role in critical care nutrition. Whether you're a beginner or a seasoned professional, this program offers the perfect platform for growth. Your path to becoming a healthcare innovator is just a step away. Don't let this chance slip away. Embrace your future in critical care nutrition with the Intensive Care Nutrition Fellowship. Your journey to becoming a healthcare hero starts here.
Hello, everyone. Has everyone been able to join us today? So, my name is Yasmin Haddad. I will start by introducing the course, the fellowship program. So the ICN Fellowship provides a rigorous interdisciplinary curriculum that encompasses both didactic learning and online training. It's tailored to meet the diverse needs of healthcare professionals, including physicians, nurses, dietitians, pharmacists, and other allied health professionals who are passionate about advancing their expertise in critical care nutrition. The ICN Fellowship is not just an educational program, it's a call to action for healthcare providers who are ready to take their commitment to patient care to a new height. This program is a unique flagship program, is offered wholly online. It's structured as 3 modules and 30 credits each. And I would like to also add that I'm very delighted to have Dr. Swifi, Khalid Swifi, join us today. He's a consultant intensivist and head of adult ICU King Fahd Military Medical Complex, adjunctive professor of nutrition at Imam Abdurrahman bin Faisal University, and also is the program director of the Intensive Care Nutrition Fellowship and VP of the World Institute of Critical Care and Emergency Medicine. I happen to be also taking the fellowship program, and I must say it has greatly added a lot of value to my day-to-day clinical practice. So let me see. Okay, so as we can see here, the Nurhan has added the links for those who wish to know more about the program, the fellowship program. So, and there's also a promo code webinar 20 to get a 20% discount for those who wish to avail a discount on the fellowship program. Okay. And it says click show caption to view the translation and all. So I'm really happy to have Dr. Khaled Swifi join me today. Dr. Khaled, the floor is yours.
Thanks, Yasmin, for introducing me, and thanks for coming to moderate the session with us. I was actually intentionally want to do that just to give you your experience and your great expertise as a very eminent fellow with us and getting the highest mark. Thank you very much, Yasmin. So today we'll have a webinar about nutrition, enteral nutrition, prescription, and what the pitfalls usually occurring in ICU, and how to avoid it, and also just to tackle important items coming in the mostly coming in the fellowship exams. So please focus. And it is very, very important to attend this actually webinar to able to excel at the end of the fellowship. So we know clearly that our food should be our medicine, and our medicine should be our food, as the Hippocrates mentioned 600 BC, and now we are following. And we are always telling that it's very important to take care about nutrition in critical care, because critically ill patient is living at the edge. There is only one chance to improve his survival. There is no second chance. So if you did not take care about your patient in ICU and maximize all aspects of patient care, the patient will not survive. Especially when you know that every 60 seconds, 10 hospitalized patients will go undiagnosed with malnutrition, and more than 50 hospitalized patients is already malnourished. It is a worldwide problem, and now start to calling it as a worldwide epidemic. So are we creating victims or survive? So we need to maximize the nutritional aspects in critical care. Otherwise, you can create a perfect storm and the outcome will be terrible. So we have two important items here to fulfill. We have a protein target and you have energy target. And both are very, very, very important. In the past, we are focusing on calories more than protein. And currently, we are focusing on protein more than calorie, especially when you see the WHO reversing the pyramid for nutrition and they put protein on the top. We are talking about protein since decades, and still people are believing that protein is dangerous or whatever. So that's why when I start to have my lecture here, I start to focus on protein first, not on the calorie. So we know clearly that we underfed calories in most of the hospital and most of the ICUs all over the world. And this study has been published clearly, and it shows that in the best case scenario, maybe 60% in Australia and New Zealand of patients receiving the target caloric requirement. And most of the center and the best center of the world is not really at exceeding 50 to 60%, including Canada and US. But how much we know mostly about the calories, but how much really the ICU patient requiring an average protein per day? Is the result of the International Multicenter Prospective Trial, has been published by Diane Hilland in 2015. Please just be with us here, just try to answer. And this is mostly questions coming in the exam. So how much ICU patient actually receive an average protein per day? Is it 0.6 gram per kg per day? Is it 0.8 or is it one? What is actually happening based on the Darren Hayland study? You have the
They can answer in the chat, correct? Yes. Let's
question
see.
and answer, the Q&A.
Where is it? So feel free to have your questions and your answers.
Yeah, so go to question and answer, and the answers there you can.
Let's
Okay,
see.
0.6. Yeah, so yeah. So actually, it is
Okay.
terrible. It is 0.6 gram per kg per day. You are correct. Thanks, Sana. So what's the average protein intake in critically ill patient based on the ASPEN guidelines? How much we should get protein per day based on the ASPEN? It is 0.8 to 1. It is 1 to 2.5. It is 1.3. So just try to be interactive in this lecture. It is not a monologue, should be a dialogue. If you can speak, will be great, but we're not allowing that.
So a lot of answers are coming in. I can see. Great, great. It says CC and
Yeah. So
E.
now you are at the end of the program. That's why most of you are expert now. So the ASPEN recommend 1.3 gram per kg per day. And when started the ASPEN to give you a specific number, an average, I spoke to Singer, Beer Singer. Oh, I told you why you choose 1.3, and we are usually going to between 1.2 to 2 as been doing. He mentioned that this is an average. You can go higher than that, but I hope that able to reach 1.3 because most of the centers they are not reaching even 1 milligram per kg per day. So what about the morbidly obese patient? How much protein they need? The obese patient is obese. They have a lot of protein in their body, so maybe they don't need high protein.
We have here a lot of B and C's. Okay, so there is both no A, just mostly B and C.
Yes, I'm telling you, they are experts. So, right, the 2 to 2.5. This is a false concept that obese patients, they are obese, they are have a good muscle build. No, they are the best patient benefit from high protein intake based on the guidelines. So 2 to 2.5 gram per kg per day, especially for people who have BMI more than 40. So ICU patient is not the best place to lose weight. This is really a misconcept. I can see a lot of physicians. I said, like, patients obese, let him to be NBO for a couple of days' time. It's not a big deal. They're not focusing much about nutrition in obese patients. No, they are actually same like a non-obese patient. They need a high protein. They need to adjust their calories, and they need to focus on micronutrient. So don't underestimate.
Yeah, it's a common ICU myth.
That's right.
And sarcopenia can take place, unfortunately, in a lot of
That's right. Yeah. So important to take care about your muscle. And I'm always telling that you need to build up your muscle. Don't wait until you are sick or you'll be in ICU or in hospital to start to really suffer from sarcopenia and muscle wasting. That's why now most of the formulas most of the companies working in the field of nutrition start to upgrade their formula and to add HMB to the formula. And the people who doesn't know what's HMB, this is called hydroxymethyl butyrate. And hydroxymethyl butyrate is a metabolite of the amino acid leucine. And we know that leucine is the best signal for muscle protein synthesis. So without leucine, you cannot really communicate with the muscle and induce muscle protein synthesis. So HMB is the final molecule as a metabolite of leucine. And HMB is the secret behind induction of muscle protein synthesis. For example, you can find like Ensure Advanced or whatever. Most of the advanced, they have HMB on board. And I'm always actually suggesting that if you're going to the gym, you need to get, before going to the gym, same like getting creatine, 10 gram or so, you need to get also HMB around 2 gram to able to induce muscle protein synthesis. And this is very clearly important in sports medicine. Okay, so do we have an evidence in critical care? Yes, we have in 2016 a study has been published in Clinical Nutrition by ESPEN. And the study, actually, it was multi-center randomized control trial across 78 centers, enrolling 652 ICU patients for 90 days. And they look at the high protein HMB versus regular oral nutritional supplement. And most of the patients were elderly, and they look even at the post-hospital discharge. And the primary outcome was 90 days mortality, and the result was strongly in the favor of HMB. So HMB able to reduce mortality and readmission rate to the hospital by 50%. And number needed to treat to prevent one death was 20. So you will find in the study NNT means 20 means that every 20 patient you treat with HMB ONS will able to make one patient survive.
Dr.
So,
Khalid,
yes.
I was just, if you can share with us how, in cases where the formula does not contain the HMB, or enough HMB, how can we supplement it in such cases? In what form, and what do you advise?
And it's a very good question, Yasmin. I don't have in the hospital, but I am personally getting powder, HMB powder, actually. It is available in most of the sports medicine shops. For you, it is available for the patient when discharged home. He can buy HMB actually from the shop, and getting they have the serving, getting 1 gram. You can get 2 serving per day or so. If you really need to build up muscle faster, you might go higher, even to 3 to 6 grams sometimes HMB per day.
Post meal would be like post with the
Yeah.
with
It's the best time to take it is with exercise, but still you can get it with the meal. It's fine.
Okay, thank you.
But as you know, of course, the exercise can really boost your muscle rather than taking protein alone. So B value was significant, 0.01. So if you stuck with the patient who is not able to build up muscle, what to do? I received this question. I was on vacation and they came last week, and I received this question many times. When we are rounding on nutrition care team, the patient is losing muscle, cannot build up muscle. What to do? Here you need to extend the ONS, high protein ONS, for 3 months to 1 year, even post discharge. Don't say like, okay, the patient recovered, will go home, he can eat now and do. No, he cannot really eat 2 gram to 2.5 gram per kg per day of protein. So you need to have a supplement here with high protein ONS, and you can continue to get that for 1 year. And somebody can ask me why. I can tell that the hypercatabolic state has been reported to stay for 1 year post ICU discharge. 1 year, especially if the patient has bullet trauma or high risk surgery. They can stay in full hypercatabolic state up to 1 year. Then you go for beta blocker. You know that we have beta 1, beta 2, and beta 3 receptors also for the sympathetic nervous system. If you block beta 3 receptor, you're able to block lipolysis. At the same time, you block muscle protein breakdown. So if you stuck also with that, maybe getting physician opinion about giving low dose propranolol 0.5 milligram per kg per day. And then we have only one anabolic steroid. Also, one dietitian asked me yesterday about that. Can I use anabolic steroids? It's the only one allowed to be used in the hospital is called oxandrolone. And oxandrolone is allowed to be getting for 3 weeks only, not beyond 3 weeks. This is very gentle anabolic steroid. It's very, very strong in building up muscle. It's very sensitive for the muscle protein senses and building up muscle. And the dose is 10 milligram BID. So don't forget oxandrolone at 10 milligram BID.
Dr. Khalid, we have a question from Ms. Mariam Hassan saying, for how long we give obese patients 11 to 14 kcal per kilogram in ICU?
Yeah, this is a very good question. But whatever they are, actually, we are focusing more in obese patients about protein. So this kind of permissive underfeeding should continue until they will not be obese anymore. Because this is even in the hospital, not in ICU, it's still the same. Like permissive underfeeding for obese patients regarding the energy target should be less. But as always telling that it is not accurate, because when we go for metabolic cart and mechanical vent, I don't have indirect calorimetry, but I have metabolic cart. I can actually look at the VCO2 times 8.1 or so, and then you can really extract the estimated energy expenditure. We found a lot of differences between what we are giving to our patients, especially the obese patient, and what's supposed to give. So don't also take the predictive equation as it is. Still, some patient, if the patient is not doing well, you might increase. But if you go by rule of thumb, it is actually permissive 11 to 14 kcal per kg a day.
Yes. So basically, we take case by case
That's
based
right.
on. Okay.
Of course, as we always tell, the guideline is just a guidance. But if it did not work, you have to personalize. That's now most of the science now talking not only in nutrition, talking about precision medicine, and now a lot of talk about precision nutrition. Okay, I hope it's clear. So it is a rule of thumb, if you want to take care about longevity, you have to take care about your skeletal muscle. Otherwise, really, actually the longevity will be affected. If you lost your strength while you are old, I believe your life is gone. If you still you need assistance, if you fell down and have some fracture, your life has been ended. So strength at the especially toward the age of 60s and above is very, 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 very important to be maintained. Otherwise, you will be in trouble. So sarcopenia is very well-known term. This is a primary consequence of aging, but it happens with the critical illness. And ICU is called, we don't say like sarcopenia by intensivist language. We are telling that ICU acquired weakness, ICU AW, okay? So ICU acquired weakness is a very big term in critical illness. Associated with chronic disease, associated with malnutrition, and associated with inactivity. So in ICU patient, the inactivity does make difference, the malnutrition make huge difference, and the presence of chronic disease, which is really cannot be reversed. Also, important term is ICU acquired weakness can prolong the mechanical ventilator days and to make patient difficult to wean from mechanical ventilator. So also affecting the outcome, and patient can stay more. And the more patient can stay on mechanical vent, it means the infectious complication is higher. We know the term called VAB, ventilator-associated pneumonia, which is common with prolonged mechanical ventilation. If the patient develop infection, will stay longer in hospital and longer in ICU, longer in mechanical vent, the cost will go terribly high. So mortality with sarcopenia or ICU acquired weakness in ICU is 1.7 x higher mortality. So critically ill patient has severe critical illness, is losing usually around 3 kilogram per week from lean body mass. Some study reaching up to 1 kilogram per day. And loss of lean body mass can accelerate critical illness, the kind of vicious circle. So what is about the evidence of protein requirement from the current ESBN guidelines in renal patient? So even in the renal patient, they don't recommend really to strictly reduce protein intake. يعني in CKD, for example, stage 3 to 5, or stage 3 to 4, for example, we are trying to reduce protein intake as much as we can, but we cannot go beyond 0.6. And so the lowest protein intake can be given even for patients who have a progressive CKD is 0.6, 0.8. And now even the guidelines suggesting you might, even if you reach lower than that or to that low extent, you might add keto analogs of amino acids. So also don't leave the patient without even simpler form of protein, without really excessive waste products. Hospitalized AKI, يعني AKI in the hospital or AKI on CKD without acute or critical illness, you can go higher to 0.8 to 1. If the patient reached to the ICU, you go to 1 to 1.3. And if the patient started on dialysis, you go to 1.3 to 1.5. If the patient start to have CRT or continuous renal replacement therapy, here you have to go higher to 1.7 gram per kg per day. Even the ASPEN guidelines suggest you can go higher to 2.5 even. So you need also to stick to these guidelines and to understand from this guidance that even the renal failure patient, you never restrict protein to that low, less than 0.6. Even the patient is progressing to CKD. And important to understand also that patient on CRT losing around 10 to 20 gram protein amino acids per circuit, and you need really to replace that, otherwise the patient will be in trouble. Not only the protein and also the trace elements. I can also tell you, I can speak about it at the end because we have some talk about micronutrients. So we need to focus, or most of the paradigm now start to focus on shifting from calories to protein and suggesting that protein needs may be more important than energy needs. And protein requirements are proportionately higher than energy needs. So important also to understand that clearly when you are treating patient. That's why I'm always teaching our nutritionist in ICU when she is actually presenting the nutrition part of the multidisciplinary team. She should comment on the risk assessment first, and then she go to the target, how much the patient is tolerating from the target, not only from energy, but the target also from protein. So she is mentioning, for example, patient at high risk of malnutrition is tolerating 50% of caloric target and 70% of protein target. So here I'm very happy that she's mentioning about protein, not only about the calories.
Dr. Khaled, we have a question from Zainab saying that what is the most suitable type of protein for chronic kidney disease in ICU?
I can tell you that when you give protein to a patient with renal failure, you are scared from what? You are scared from nitrogenous waste products. More simpler protein, the more the protein is simple, the less nitrogenous waste products. And for example, the amino acids is having less metabolic nitrogen waste product than the whole protein. So, for example, if you have a formula with whole protein,
so peptides, you mean peptide for
you go to peptide. If you don't have, if you go down, then amino acid even will be far better. That's why amino acid, even infusion, sometimes even acute kidney injury can improve the renal blood flow and improve the renal function. So amino acid is the best, followed by semi-hydrolyzed formula like peptide formula, and then the last thing is the whole protein. If you can find a mixture of amino acid plus the keto analogs, it will be much better for the patient outcome. Okay, but actually, so far we don't have a keto analogs intravenously or like that. We have only like sachet. And I don't know, there is an underproduction from the companies, nutrition companies regarding keto analog. Maybe in the future you'll find keto analogs formulas, like closed tube formulas, you'll find keto analog in intravenous. So the simpler form of protein is much better than the complex form of protein. So here, we in the Count opinion in 2013, they found that ICU patient usually getting 50% of EN goal, and no modular protein is added, and protein delivery not exceeding 0.6 gram per kg per day, and 14 days protein depth is 1.5 kilogram, and 14 days calorie depth is around 20,000 kilocalories. So imagine that patient staying in ICU for 2 weeks, losing at least 1.5 kilogram from the muscle mass, as well as losing 20,000 kilocalories as a depth. And I can tell you more, he's getting around maybe 20,000 ml of fluid extra in his body. And usually when you around the ICU, ask the nurse, how much cumulative balance, how much is the patient accumulating fluid in and out since 2 weeks, mostly telling you at least 12 liters, so 12,000 ml. So this also will add more to the risk of the worsening of the muscle. So when you are going to initiate nutrition, you have to understand that the how you are feeding patient in the first week of ICU will change quality of life months later. So focus on the first, because also most of the studies showing that after 1 week, usually patient is getting increased caloric and protein intake in most of the centers. So the golden time is the first week of intensive care. You need to feed them, you need to try to optimize the nutritional intake and to achieve the optimum feeding. So before initiation, you have to understand that you need to fulfill certain requirements. Enteral nutrition tube position has to be confirmed by X-ray. Refeeding risk should be assessed. Electrolyte in serum should be optimum, and patient should be hemodynamically stabilized and resuscitated. So important to understand that. If we did not fulfill this requirement, the patient might get complicated. And for example, I can tell you, one time I was rounding an ICU in the weekend, I think it was Friday. And I saw the patient in the morning. I found his phosphate is very low. I was a lady, actually. Phosphate is low, 0.4, I think. The normal in our center is 1.5, like that. So I found 0.4, and I told them patient mostly develop refeeding syndrome. Just stop the feeding and start aggressive phosphate replacement. So I think the ICU fellow was busy with the patient crashing in second bed, so he forgot to stop and give phosphate. After 2 hours, the patient had cardiac arrest. So hypophosphatemia can lead to cardiac arrest. So don't really underestimate that sometimes by your nutrition prescription, you might really kill the patient. So this is not a joke. So be sure that you have an optimal electrolyte before starting. If the electrolytes start to come down when you start feeding, you just hold on and just give aggressive electrolyte replacement before going to increase the caloric intake. If the patient is unstable, lactate is high dose vasopressor, Now they said 12 mic, and with the new guidelines, said 12 microgram per minute, consider a high dose. You should not start feeding unless the patient start to stabilize, lactate start to come down, and leofed dose start to go down less than 12 mic per minute. Okay, don't feed patient without doing X-ray for the feeding tube. We have seen a couple of patient tube going into the bronchus with a lot of complication later on. So this is a very simple items, but they're actually missing can cause great harm. And if you look at the guidelines since 2018, 23, and even some sort of update to 2025, they are focusing mainly about to avoid iatrogenic harm. The word iatrogenic means what? Iatrogenic means that you are the one causing that. So the patient admitted to the hospital to get benefit, but to induce harm, this is terrible.
So, Dr. Khalid, from my understanding, you are advised in order to, reduce any complications of the refeeding syndrome, the feeding aspect plays a big role, correct?
That's right.
That's why we have to start low and gradually increase while monitoring electrolytes. Is there anything else you would like to add with this regard to help?
These electrolytes, you have to optimize electrolytes before starting, because the patient is having harm because of when you start feeding, you spike your insulin level, and as spiking insulin level will shift all electrolytes inside the cell. And the harm coming from hypokalemia, hypophosphatemia, hypomagnesemia. Some patient has arrhythmogenic heart, and I can tolerate, for example, hypokalemia, but other patient, if you go to hypokalemia, will develop ventricular fibrillation and will have a cardiac arrest.
This is why you said stop the feeding, correct the electrolytes.
And start on lower rates, that's right.
Okay, great. And we have a question here from Shuruk saying, how to deal with high protein needs in ICU in developing countries if RTF or supplements are not available?
You have to go to blenderized feeding. We don't have other than that, because I can see a lot of low resource companies, they are using blenderized feeding because it's the only option. If you don't have modular protein, it's the only option to go to blenderized feeding.
Also, we have from someone asking about the refeeding aspect, how long of thiamine should be provided?
For how long you can reduce the caloric intake down to 10 kcal per kg per day, you mean something like that?
Thiamine supplementation for refeeding.
Sorry, what supplementation?
Thiamine.
Timing. My timing, I'm telling you. You start by 10 kcal per kg per day, and you monitor the electrolyte. If the electrolyte is not coming down, and the patient does not look having, for example, vernix encephalopathy or Korsakoff psychosis, it means that he did not develop refeeding syndrome, and you can go higher and higher like that. So you don't have a specific time. You can monitor the patient day by day.
Thank you.
So feeding of shocked patient, stable or decreasing dose of vasopressor is not a contraindication to early enteral nutrition initiation. So I don't also say the opposite. Don't tell the opposite. The patient is on norepinephrine, I will not feed him. No, this is also wrong. You can feed him trophic, you can go a little bit higher than that until he's off vasopressor. But the main issue is to understand that should be stable. Lactate should be down, 4 down to 2. Don't give feed patient with lactate of 4 and above. Or Levofed, it was 5 mic, now it's 10 mic after a few hours of 15 mic. This is totally absolute contraindication. But if the patient was on 50 mic of Levofed or norepinephrine and then start to come down 25 and coming down to 15, and here you can start to consider to give him trophic feed. Okay, so norepinephrine itself is not contraindication, but the worsening shock or unstable shock is a contraindication. طبعا there is no consensus about what's the dose, but I can see the ESPEN start to answer in the last version by 12 mic, and if above 12 mic you don't prefer to feed the patient, below 12 mic start to feed. The Australian guidelines, they are talking about lactate less than 4. Any patient lactate more than 4, don't feed. Less than 4, you start trophic feeding until to be less than 2, and then you can go higher. Okay. How you are going to start? You have to understand when you are going to start even. Evidence from clinical studies showing that all except answer, please. The early enteral nutrition is associated with preservation of gut integrity, favorable mucosal immunity, higher infectious rate, and decreased cost. Which ones? When we found in the MCQ except, it means they are asking you to choose the wrong answer.
We have a C, C, C.
Oh, so it's an easy question. Okay, so it's actually associated with lower infectious rate because when you start to feed the patient, you stimulate the IgA release from the mucosal surface, and the IgA can give a strong mucosal immunity.
I think we have a very smart audience and crowd.
Yeah, because they are actually at the end. We only 3 weeks will finish the fellowship. So delayed feeding is associated with worse outcome. We no doubt about that, and late feeding associated with actually higher risk of impaired gastric emptying, increased caloric and protein debt, risk of gut atrophy and bacterial translocation. So don't really to be really late in feeding, but also don't be very early. Don't start very early within 12 hours or so. And I've also get irritated when I found that the intensivist, my fellows, they know that I love nutrition, example. So when they saw me, my patient came like a couple of hours ago, I put nasogastric and start feeding. This is also not optimal. That's why the new guidelines, they mention clearly, start within 48 hours. They give you 48 hours, not like previous guidelines telling 24 hours. Did you ask yourself why? Do you ask yourself why, Yasmin?
Why they do that?
Yeah, why the change from within 24 to within 48 hours?
Because with regards to the to make sure they're hemodynamically stable, you mean? Like in terms of like stability for the patient?
Yeah, this is right. So you first, when your patient admit to the intensive care, focus first about what? About the stability. You need to stabilize patient first. Patient need fluid, I need to resuscitate the patient. Patient need norepinephrine, I need to give norepinephrine. Patient
Exactly.
has an infection, I need to give antibiotic. So we need to focus first on resuscitating by ICU language. It's called by resuscitating your patient.
So not too early, not too late. There's always that mark.
That's right. Yeah. And also I can tell you more that you need to have time for imaging study, for procedure. Patient when admitted early to the ICU, mostly they need to have procedure, they need to send them to CT scan, to ultrasound, to like that. So if you kept on stop feeding on and off, this is not, or if your patient is already on feeding, they not take him to CT scan and not take him to ultrasound. So first resuscitate, do your imaging studies, take labs, stabilize patient, and then you start to think about feeding. Okay.
Dr. Khalid, we have a question by Amna Tahir. It's related to TPN. So I have a concern regarding serum phosphorus, potassium, and magnesium. Minimum to start TPN to avoid refeeding syndrome, even 10% dextrose in TPN.
How much do you need يعني in TPN?
So basically,
phosphorus?
she's concerned, like I believe her question is with regards on how, when on TPN, to help reduce any risk of refeeding. So how to start, like
Usually, if you attend my lecture about the parental nutrition, I have 10, 10, 25. I'm always telling 10, 10. Remember, 10, 10, 25 means that 10 millimole per liter of calcium, 10 millimole per liter of magnesium, and 25 millimole per liter of phosphorus. This is the best combination to start with. Okay. And mostly we are not really giving, usually in the TBN, you give a standard kind of formula. So this is a standard. You don't really go higher and lower with this standard. What you do, you actually give extra if you want outside the TBN. So we don't really want to play much with the TBN. Give the standard and give extra if you want, but don't really going up every day. I'll give 25, tomorrow 35. No, this is not really a good practice. It is harmful and unsafe.
especially
Because
peripheral. So whether it's peripheral or central,
it does matter because but it is not, if you put a TBN, it is over 24 hours or at least 18 hours or so. So will not cause harm. And important to understand that standard TBN should be there. Don't go beyond the standard, and then later on you can give extra if you want.
she mentioned here that she meant, sorry, enteral nutrition with TPN. Oh, so if she has TPN on with the patient, and there's also, and so together, there's enteral and TPN. They're both being used as a feeding. So if that's the case, also same thing. So the enteral will be, if it started at trophic, like low start.
Yeah, same thought like supplementary parenteral or whatever. Yeah,
Exactly.
same scenario. You have, I'm telling you, 10, 10, 25 should be there to reduce, to improve really the replacement, and also to prevent the some sort of precipitation. If you go lower with phosphorus, the solution will be precipitated.
Okay. Thank you, Dr. Khalid.
So we know clearly that from this called, what is called Kaplan-Meier survival curve. If you found this curve in any article, this is called Kaplan-Meier survival, not mortality, it's survival. So anything higher than that, survival is higher with the intervention up, and survival is lower with intervention down, okay? So here, early feeding associated with higher survival based on the Kaplan-Meier survival curve. So still so many questions need to be answered. How we are going to make it? So to initiate very early, to start full caloric requirement, to advance fast over 3 days. Do you agree about that or not? Write in your chat box.
Attendees, you may answer the question which is shown on the in the Q&As.
Say yes or no.
So we have a no, and then no, no, no.
Yeah, so they are expert, I'm telling you. So when to start? Within 24 hours, within 40 hours. We mentioned within 48 hours. This is the new guidelines. And start feeding within 40 hours associated actually with higher rate of survival. This is based on SBIN starting from 2018. So why start low with low calorie, not full calorie? We know from this diagram that in early acute illness, the patient can generate 50-75% of glucose requirement. So maybe you don't really need very high calorie when you start to initiate feeding because of this kind of catabolic states. And second question, how best to calculate? Of course, you know, all of you, halas, about Indirect calorimetry, of course. We need to achieve nutritional targets by indirect calorimetry, and feeding closer to recommended calories and protein target is associated with more favorable clinical outcome. It's based on very strong evidence. So on diet calorimetry, as you mentioned, as you know before, that gold standard method for determining energy expenditure. If you don't have, use metabolic card. Ask your respiratory therapist, do you have a metabolic card? Can you provide me with VCO2 or not? And just multiply by 8.1. Called indirect because caloric burn is calculated for measurement of oxygen uptake and resting energy expenditure using the Weir equation. So you need how much oxygen consumption and how much carbon dioxide excretion. This is the shape of the indirect calorimetry. You can use it also in non-invasive. You don't need a tube. Yani maybe with mechanical vent or without mechanical ventilation. Predictive equation, of course, is more than 200 equation, accuracy 40 to 75% compared to IC. The most famous Harrison Benedict, you know very clearly, and simplistic equation to use 25 to 30 kcal per kg per day, depend on the stage of the critical illness. So what about obese patient? Use actual, adjusted, or ideal? We use adjusted on the ESPN guidelines. So adjusted body weight, if the patient, you give ideal body weight plus 25% actual minus the ideal. For example, if the patient actual body weight 106, the ideal is 70, based on the height here. Adjusted body weight is equal to 79. So if you calculate your energy target on 106, is terrible. You calculate on 79. And the energy requirement for this patient is 2000 kcal. If you don't make headache for yourself and to calculate, use the permissive underfeeding with 11 to 40 kcal per kg of actual body weight. This is from 2000 ASPEN guidelines as well as 2022. It's called permissive underfeeding. So how to start full hypo or trophic feed? We said to start hypocaloric feeding. Trophic feeding should not be started in all patients. Calculation of energy target, use a simplistic equation. And here, important to focus on true dry weight. If the patient coming to you to the hospital, I ask always the nurse to take 3 kinds of weights. The initial weight admitted to the hospital usually it's called dry weight before getting fluid and all the stuff. And then to calculate the ideal body weight based on the height and calculate the adjusted body weight if the patient is body mass index above 30. So we start based on the new guidelines on 12 to 17 kcal per kg per day. You, with time frame about 7 days, you reach 25. And after 7 days, you go target 30 kcal. High risk of refeeding syndrome start by 10 kcal per kg per day. In obese patient above 30, use adjusted body weight, as we mentioned. So we have different kind of feeding, and it's called hypocaloric feed, when you intentionally use less non-protein calories. And we have the same hypocaloric feeding. We start for all kind of patient in ICU now. We start with 12 kcal per kg per day. Trophic feeding, when you feed the patient at rate less than 500 kilocalories per day, just for gut integrity only, not as a kind of calories. And you have permissive underfeeding is for the obese patient, intentionally giving 40 to 60% of caloric target or caloric need. So trophic, you practice a minute volume of enteral nutrition in order to maintain the gut integrity and to preserve mucosal immunity. And as I told you, when you start to feed enterally, you maintain the IgA, immunoglobulin A, inside your mucosa, they got mucosa, and you're able to reduce the infectious complication and translocation of bacteria. So what's the indication for trophic feed based on the guidelines? Which patient require trophic feed? Except all of this, except means that you choose the wrong answer. Early 6 days of mechanical vent and RD with acute respiratory distress syndrome, high risk of refeeding syndrome, post-anastomotic gut repair, and early acute phase within 48 hours. Which one is wrong? This is a difficult question. We'll see the fellow at the end of the program, how they are behaving. Anonymous attendee, we don't know her name. Calling one, Maha one, Maria. Four, Sarah. So there is some discrepancy here. Yes, me.
Sorry. I was on mute. I just realized. I was just talking to myself. Okay, so we have different feedbacks. Okay, interesting.
Okay, because I believe difficult question, but many they answered correctly. So this one is wrong because we did not say like any patient with early acute illness will start with trophic feed. We said like all patient to start with 12 to 17 kcal per kg. You start with 12, but trophic feed is less than 12. Okay, so this is wrong. What about post-anastomotic? Yes, if you give to anastomotic, patient has anastomosis, resection of the bowel, and re-anastomosis, primary anastomosis. Giving trophic feed will improve the gut integrity and improve healing of the anastomosis. High risk of refeeding syndrome, of course, you start with 10 and below. Early 60, this is a trick here. We have a study, we'll see it together now, that patient with ARDS is the only patient might really did not get harm with trophic feed if you continued for 1 week even from the ICU admission. And trophic feed versus full feed in patient with ARDS on mechanical ventilator. ARDS, of course, is a severe disease and patient requiring aggressive mechanical ventilator support. Patient who get 80% of caloric target versus patient who get 25% of caloric target for 1 week, there is no actually outcome problem. Okay, no difference in mortality, ventilator-free days, multi-organ failure, infectious complication. Okay. Trophic feed in post-anastomotic leak. Important to, we have a meta-analysis, has been published 2011, and another study has been published 2021. Early enteral nutrition makes anastomosis stronger with greater collagen and fibrin deposition. This is in the opposite of the idea of the surgeon. Surgeon like to keep patient NDO for 2 weeks post anastomosis, which really knows that this is not in the best interest of the patient. So no worsening of the anastomosis if you start trophic feed early. No anastomosis dehiscence. So how to advance over 3 days or over 7 days? Answer, please.
So let's see the answers. A lot of answers are coming in. So we have a lot of 3 days, 3 days. Then we have over 7 days also.
We have Sarah Al-Otaishan here. All her answers are correct. How do you know this? All this?
We have
More,
more B.
So most of them are B. Yes, they are expert. So over 7 days, we don't really reach full caloric requirement over 3 days. Okay, over 7 days. So when I attended Brussels conference 2022, I found really this is the first time to categorize patient into early acute phase of critical illness, late acute phase, early acute phase within 48 hours of patient admission to ICU, late acute phase within 3 to 7 days, and then you have chronic phase after 7 days. So early acute or late acute, this is you start here 12 kcal per kg per day, and you go higher gradually until you reach to the target at 7 days with 25 kcal per kg per day. And after, when you reach to anabolism here with chronic phase and rehabilitation, you go for 30 to 35 even if you want. But so one size doesn't fit all. So don't treat all patients the same way.
Dr. Khalid, we have a question. For obese patients, protein needs should be based on ideal body weight, right? Yes or no?
Yes, agree 100%. For the calories, we use adjusted weight. For the protein, you use ideal weight. But if the patient is not obese, you use actual body weight. So first 48 hours is the early acute phase regarding the protein. There is endogenous calorie production, and then you start here to get higher. If the GRV is high here, you might start to think about supplementary parenteral nutrition if the patient is not having enough energy. Also for the protein, I don't have the graph here, but it's important also within first 48 hours, you start with 0.8 gram per kg per day. Up to 7 days, you go gradually higher to 1.3. And so important also for the protein to start low and go slow. Otherwise, also the autophagy, you stop autophagy early if you start high protein, and it's not in the best favor of the patient. So same like if we don't really have overfeeding, especially early in acute illness, because associated with liver dysfunction, infectious complication, prolonged mechanical ventilatory support, glucose metabolism disturbance, which is all is associated with worse outcome. Everything getting worse when the patient is hyperglycemic, with increased mortality in critical ill patient. Even the acute kidney injury is getting higher. Infectious complication is higher. The organ dysfunction, you can see here the graph with increase. If you fed patient higher with hyperglycemia, the mortality is getting high as well. So clinical burden of hyperglycemia is terrible in ICU. Is for systemic scoping review here showing that patient with hyperglycemia having high risk of mortality, independent risk factor for infection, hospital length of stay is higher, disease severity and healthcare resources also utilization is higher. So cutoff before under feeding complication is important. So we don't need to have an overfeed and don't want to also have a lot of caloric depth because also is worsen the outcome. Because we know clearly if you have a depth of 10,000, here you start to have a complication. Not start, you have complications certainly. And I mean you can swear that the patient has a depth of caloric depth of 10,000, he will have significant complication. If you start to have a depth of 4,000, problem here to start. Critical value 8,000. Never exceed 8,000 caloric depth. Okay? So don't want to see the patient in ICU have 10,000 caloric depth. This is terrible. Means that you are not doing your job. So we need to balance the underfeeding and overfeeding to achieve a good outcome. Both are harmful. Right. So about the feeding of hemodynamically unstable patient with reduced blanchenic blood flow, especially with fibers, is also not good because gut ischemia is common and ischemic bowel necrosis and ileal perforation is there. So also be sure that you don't really overfeed those categories of patient with severely unstable Otherwise, will end with ileal perforation, which is fatal. It is not that common, but it's fatal, especially with small bowel feeding. Why hypocaloric? You have propofol on board. You know propofol or not? Propofol is the most common sedative used in intensive care for patients on mechanical ventilator. You have to understand that very clearly. So approximately propofol giving around 500 kilocalories per day. So you need to deduct that from the patient. And the endogenous caloric production is 50 to 75% with severe hypercatabolic state. So very important to deduct the total caloric target from how much propofol are getting, 1 kcal per ml. Not only that, but also the CRRT. You know citrate, some of the you are expert with the citrate, using citrate anticoagulation. It gives you around 300 to 500 kilocalories as well. If the patient on CRT, ask please the physician if the patient is getting citrate as an anticoagulation in the machine to prevent clotting of the machine, you have to deduct 300 to 500 kilocalories. So you have propofol 500, citrate 500, you want to have 1,000 kilocalories. If the patient caloric target 2,000, you need to give him only 1,000. This is very important. This is a difference between a good nutritionist and not good nutritionist. This is Peter Wege's study when he shows that early high protein intake can associate with better outcome, but only in non-septic patient. When you have patient with sepsis, you need to be conservative. You don't really go faster with protein intake. Okay? But if non-septic patients, especially trauma, for example, you can go very fast in increasing protein intake. How to achieve hypocaloric feeding? So you need to start with low calorie, low carb, and high protein. This is the only way to achieve hypocaloric feeding. If not tolerating gastric feeding, don't jump quickly to parenteral nutrition. Here you have post-pyloric feeding, and we have in our center this kind of tube. We are inserting it with the endoscopy. I make a plan with one of the gastroenterologists. Whatever I need to have a small bowel tube, I am calling her. Please come, Mariam. She is Mariam coming, and she is putting the tube in 15 minutes, and then the patient life changes rather than to go to parenteral nutrition. Okay, if you stuck with you don't have post-pyloric tube or cannot insert, or patient cannot tolerate even post or contraindicated, is the time to start. Don't delay parenteral nutrition. No problem to start parenteral. Yes.
Sorry, I have a question. So do you think we underuse post-pyloric access?
100%. I can tell you 100%. Because my experience, because when you ask gastroenterologist, maybe he is not expert as well. And we actually gained experience in how to insert it by ourselves. So we bought the tube, and then we make a deal with the gastroenterologist, and then they start to insert it. But the insertion is not taking long, and we stay with the patient for a long time. And I have many patients in my hostel going home with this tube. It make difference, yeah.
So which cases do you see that would require this and in your practice?
The patient who is having gastroparesis, especially long-standing diabetes, whatever they are trying to feed them, they have a very large GRV and they're not able to tolerate the gastric feeding.
Aspiration and okay.
Yeah. And also, if the patient requiring catecholamines like norepinephrine for quite a long time, aggressive mechanical ventilator, all this stuff is really giving you a hard time to feed them through gastric tube.
But what about if a patient is in already palliative care, but has been long-standing PEG and started having aspirations? Do you still advice for post-pyloric in such cases? Hello? Wait, is it disconnected? Dr. Khaled? Can you hear us? I think. Okay, so Dr. Khaled? So we have here, I think a glitch, something. Let's see. Hopefully he can join us again online. Can you, wait, hello? Hello? Um, I don't know what happened. So can you hear me, attendees? Thumbs up if you can hear me. Okay, great. So we'll have, I think it's from Dr. Khaled's, hopefully he can join us again so we can continue. Let's see. So do you have, if you have any questions, now is the time to share your questions. So we have Dr. Khaled and
Yeah, and also again, there is a network that was actually electricity issue.
no problem.
Okay.
Good to have you back, Dr. Khaled.
Mm.
We have actually an interesting, like I saw it, but I thought to keep it for later. So we have Zainab who shares a real, like case scenario, and she would really want your expertise with this regard, because sometimes we know what to do, and maybe this is the right thing to do based on like guidelines, based on all of the experience we have as dietitians, but then we have a lot of obstacles, and so communication with the MDT is very crucial. So how can we overcome this? So for example, here she says there is a neuroconsultant who kept an acute stroke patient NPO for more than 3 days because he was concerned about pulper. Yeah, I suggested an ENT, but he refused. What is your opinion? He says that the patient will not die from not eating or under eating. After that, he prescribed yogurt, although she informed him that yogurt is not safe according to the protocol. She just wants to know uh, what she can do, or with regards to this, situation.
I know it's a difficult situation, يعني, especially if dependent on the center, if they don't have really a good education and understanding the value of the nutrition, very difficult to win. But what our experience is telling that provide education indirect to all these kind of people with lectures or with courses like that, and with time they will come along your opinion. Second thing is you might really start to create nutrition care team. If you have a nutrition care team, everybody is listening to that. So nutrition care team will be composed of a senior physician, senior nutrition dietitian, senior clinical pharmacist, and senior nutrition nurse. They are rounding all over the hospital for complex situation. So if you are a dietitian working in with this categories of physician and the patient like that, and you feel the patient might benefit, you refer the patient to nutrition care team, and they are the one to speak to him, and he will listen to them clearly. This is the only two solutions. So continue on long run educating indirectly all categories of physician and nurses and nutritionists, and on the other side, start to implement the nutrition care team strategy.
I would also like to add it's very important to have like as you said, Dr. Khalid, like the MDTs, and then have evidence, whether it's related to tangible information at hand, comparison of what is this doing, and evidence based, and like the repercussions of what's happening, as well as documenting everything. So whether what she believes should be done and how this has not been, the case because da da da. So documentation is also a very crucial part of our work.
Definitely, she will document that. She can start to talk to the chairman of the unit, the head nurses, like that. So she still can really try to negotiate for it, but at the end, it is not in her hands. So if she's stuck with that, you need to set in her department and trying to improve really the nutritional delivery in the hospital. As I told you, we only win when everybody get educated. We started to win when we have nutrition care team. By the way, maybe by next week, I think you'll have a nutrition care team, or the week after. I believe next week you'll have a week about nutrition care team and how to formulate that team. And maybe you can have a chat about that also in the future, how to formulate, because I have a policy, I have a guidelines, I have a format, so you can get all that and implement in your center.
Great. Thank you, Dr. Khalid. Very informative.
Okay, so my take-home message here, we need to avoid iatrogenic harm. This is the message from the most of the new guidelines, because also overfeed or inappropriate feeding might cause harm, same like underfeeding. So don't also underestimate the effect of inappropriate feeding. The 2019-2023 Beer Singer, he mentioned clearly early full enteral and or parenteral nutrition within 48 hours should not be used in critical ill patient to avoid overfeeding, but we should provide them with hypocaloric enteral nutrition to be started and initiated and advanced over 3 to 7 days. And to achieve or to avoid protein malnutrition, early high protein formula, not high protein feeding, high protein formula to be used to achieve average protein intake 1.3 gram per kg per day, and to be prescribed over within 48 hours, and to achieve that target in the first week over the 7 days time, not also to achieve the target within 48 hours. You start with 0.8 and gradually reach to 1.3. In the rehabilitation phase, you might go to 2.5 as well. So difference between SBIN from 2023 and 2019 and ASBIN 2022. Time to initiate enteral nutrition within 24 hours, within 48 hours. Amount up to 25 kilocalorie per kg over 2 to 3 days. Here you start hypocaloric early at achieving target slowly over 3 to 7 days. Enteral nutrition in shock, no contraindication, but just monitor the tolerance and restate your patient first. Here, no enteral nutrition in uncontrolled shock. In the past, we were feeding all patients on norepinephrine without really resuscitation, but currently they have to restate patient first and the shock has to be controlled. If uncontrolled shock, don't feed them. Enteral nutrition is insufficient or contraindicated, consider parenteral early, because in the old guidelines, the new guidelines, so it will be in within 3 to 7 days, not earlier than that. What about the elderly patient? Elderly patient, they need a specific consensus, and there is a guidelines in the SBIN 2022 for the elderly patient. I believe you heard from Dr. Ayman, I think last week about that one. Higher percentage of calorie. Here maybe 30 is important, 30%. Higher amount of protein, at least 1 gram per kg per day. The only peptide-based formula clinically shown to help to control blood glucose in ICU. EN with fiber containing product level average of 25 grams per day. The elderly patients have a problem with microbiome diversity. They need fiber. So if you have an old patient at home, you should give him probiotic. You should give him containing formulas. Hydration is very crucial, at least 1.6 liters per day for women and 2 liters per day for men. They should keep hydrated. Micronutrient is important, very, very, very important for this. They cannot have an adequate neurotransmitter without micronutrient. They don't have a good mood without micronutrient. Believe me, if they give them micronutrient for elderly patient, their mood will be totally different. Dietary restrictions that might limit dietary intake and potentially harmful and should be avoided. This is very, very good statement, and I love it. Don't jump on elderly patient and tell him, oh, this is totally is wrong. Don't eat high sugar. Don't eat high salt. Please restrict that. He is not eating. Leave him to eat. Whatever he's eating a small portion. So here, you don't restrict anything from portion or whatever in the elderly patient. Refeeding syndrome is common and associated with micronutrient deficiency. When you go to micronutrient in 2022, they mention clearly there is a new guidelines also for that. And they mention is refeeding is common, is not uncommon. And a lot of people is not aware about that. And there's a problem with refeeding syndrome is a micronutrient deficiencies. Inflammation induces micronutrient deficiencies and should be supplemented. So don't tell me the patient stay in ICU for 2 weeks having severe sepsis, very high catecholamine, septic shock, and by the end of 2 weeks he is not depleted for micronutrient. He should be replaced. Chromium is very crucial for blood sugar control by activating translocation of glucose transporters and reduction of insulin resistance. So chromium has to be optimum also. Chromium in enteral nutrition recommendation 35 milligram per day, while in parenteral 10 to 15, half dosed nearly 10 to 15 milligram per day. In parenteral nutrition, we need to increase the zinc, selenium in case of increased GI losses. And not only that, but also patients on CRT, they are losing zinc and selenium there, and water soluble vitamins like vitamin B and folic acid and vitamin C as well. Reduce copper and manganese in cholestasis, and reduce manganese and chromium in long-term patients. So this is a recommendation from the micronutrient guidelines, and I advise you very important advice. And today I have done this. And in one of my rounds, I saw a patient went for cardiac surgery, cabbage, aortic valve replacement, transferred to rehab center, came back with septic shock, intubated, extubated, is an 80-plus-year-old, and the patient is not doing well. His mood is low. He has weakness in the swallowing. He is agitated. So I told him we need to start micronutrient. How to start micronutrient here is important to understand also in those categories of patients, the absorption from the gut is not great. You need to give the micronutrient, trace elements, and vitamins through the intravenous line. So these categories of patients, they benefit from 5 to 7 days micronutrient. You will find their life will be completely changed. Their mood will be much better. Their strength will be much better. Their life will be totally different. So please advise, if you are not taking care of parenteral nutrition in your center, advise the physician, please replace micronutrient intravenous. We need trace element, we need vitamins for 5 to 7 days, and you will find the difference. And tell me about the difference. Even if the patient mechanical vent and difficult to wean, you will find significant improvement in weaning from mechanical ventilator and able to wean the patient from mechanical ventilator. Don't underestimate the effect of we are concentrating about macro. No, the micro is not, I believe, is much more important than micronutrient even. Aspen guidelines 2022 energy target in the first week 12 to 25 kcal per kg per day. Protein target 1.2 to 2 grams per kg per day, either enteral or parenteral with similar caloric target. They don't find difference between enteral and parenteral nutrition. I don't have really a strong evidence to recommend against one of them based on the new studies like Nutriria trial. Supplementary parenteral nutrition only after 7 days, not before that, before we're starting after 4 days or 3 days, 6 hours, and use any kind of lipid emulsions. This is also here, they mention clearly they are not against fish oil or olive oil or whatever, but they don't have a strong consensus studies to say like this kind of oil is better than other kind of oil. But of course, we know that mixing of oil together, like olive oil and fish oil and all this stuff, will have a better outcome on the patient. Summary from the latest ASPEN guidelines also mention clearly that no difference in clinical outcome were identified among numerous nutrition interventions, including higher energy versus low energy, protein intake, isocaloric parenteral nutrition, or enteral nutrition, supplementary parenteral, or different intravenous lipid emulsion. In the meantime, clinical judgment and close monitoring are needed, and patient has to be treated individually, and recommendations can be changed on daily basis. It means that, again, they actually suggest, provided that we don't have a strong evidence to suggest anything over other, you know all details, you are expert, and now you start to really individualize. You need to apply precision nutrition. So how are you going to make it? We need to initiate early. We need to start hypocaloric. We need to advance slowly over 7 days. This is the best way to have feeding. And you need to be cautious in critically ill patient, to be especially surgically ill patient. If the GI intact, start early enteral. If not intact, you look at the risk. If the high risk patient, start early parenteral. If low risk, start late parenteral. After 7 days, patient not achieving more than 50% of caloric protein target, start supplementary parenteral nutrition. This is according to the best evidence from the guidelines. And high protein is a must. You don't ignore the effect of high HMB during recovery is a must as well. Start low and go slow and build up over 1 week. Thank you very much, and floor open for question.
Thank you, Dr. Khalid, for this very informative lecture that really covered all aspects of enteral feeding. And let's go on.
Sorry, Yasmin, but just I answer one phone, and you can have.
Thank you, Sana. Thank you. So can Dr. Khalid please summarize important notes, if any, for third module exam? It is as previous 2 modules. Yes, once he's finished with his call, we can review that, of course. Very informative lectures. We'll be implementing in practice, inshallah. Thank you, Amine Karimi, for this lovely feedback. And so if anyone wants to share any questions with regards to today's lecture, please feel free to drop your questions in the Q&As. And upon Dr. Khalid's return, we can discuss further. So have you all taken module 1 and 2, or some of you it's just module, because they're not all together. Not everyone, I believe, has taken them all together. Some maybe have taken them separately. Okay, so a lot of you have taken them together, it seems. Okay. Yeah, it's quite useful to have them And would you like recommend the course? I mean, did you feel like it was interactive and hands-on for day-to-day practice? Okay, thank you, Sarah. Yes, both Sarahs. Okay. All right. Yes, yes, very good to hear. And of course, it will keep, evolving for better to better with all the great, feedback from participants. You would have liked to have scenarios. By scenarios, you mean like more case studies, Nisha? But the only thing, if we can add any lecture about anemia. So what exactly do you need to know about anemia? Like anemia, any specifics? Because it really affects patient care. Yes, I mean, yeah, I will share that with Dr. Khalid. Thank you so much.
Okay. And
So
sorry for that because I'm on
no
call.
worries. I was chatting with the participants. They're quite interactive. It's very lovely. So I have some questions for you, Dr. Khalid, because we have a few. So there was a mention of, of course, they would like to have more information regarding the third module exam. So I mentioned, yes, this will be discussed, like to important notes regarding the third module exam, and also. They are very happy with the outcome of the ICU fellowship, and they so far have benefited a lot. You have great feedback here, but also they have suggested like to have. Nisha said would have liked to have more scenarios. I think she meant like case studies. And also, Sarah mentioned that she would have liked to know more about anemia. So if there was anemia coupled with all of in the critical cases, how would
I think it's a very good idea. I'll write it. So anemia, you need to know more about anemia and how to fix it. We have now new iron, it's called Inject, can be given to the patient and can increase hemoglobin by 2 in 1 week, 2 grams in 1 week. So I believe we can do that. Yes.
Especially I believe for CKD patients as well, and different cases post op and pre op, like because it really affects patient care. Correct, yes, it does. And thank you, Dr. Khalid, for your valuable input. That's from Zainab. And how to treat it. Oh, also if there was some talk also about drug and nutrition interaction. That's a suggestion by Sarah.
Yeah. There is actually lecture. There is a week, coming week or after coming week, there is a lecture and the whole week about drug food interaction.
Okay, great. And there's also here
Specific week.
more clinical cases on TPN, if possible. That's also something suggested by the attendees. And Dr. Khalid, the floor is yours. If you can, of course, share with us more information regarding the third module exam.
Yeah, I'll try to summarize what's really important in critical care nutrition today. This is specifically done for the exam. So we are not away from what we are talking about. This is a whole journey from admission to ICU to leaving ICU and even at home, what patient has to do both in both ICUs, sure. So it will not be away from what I'm talking about. So don't be really scared about the final exam. And there is no final exam. The exam is we actually module 3. So just module 3 also is very, very important in the exam.
Dr. Khalid, I have a question with regards to like diarrhea, because I've noticed it's common, in some patients, especially on those long-term, PEG feeding. So diarrhea and enteral feeding, how often is it truly due to the formula versus other ICU factors?
It is more common due to ICU factors than the formula. But also I need to tell you that early في acute illness, the patient cannot tolerate high osmolarity formula. So please don't write high osmolarity formula. And I can remember one company brought for us one formula for intensive care, and it was a very nice formula containing a lot of micro and micronutrient. I started to use it as a closed tube feeding, and I found all patients having diarrhea. And when I look at the formula, I found that osmolarity is terrible. يعني مش 600 something يعني one big number. So also I suggest not to use a high osmolarity formula, especially in the first week of critical illness. This will reduce significantly the diarrhea.
Interesting. Thank you. This is very helpful. Also, gastric residual volume, so GRV, are they still relevant or are we overreacting to them?
We are overreacting always to that, but still, يعني from my clinical experience, still relevant. يعني I cannot really feed patient with 500 ml of gastric residual volume. يعني does not make sense. And that's why the Canadian is still putting the gastric residual volume. But if they ask you about the evidence, we have an evidence from 3 randomized control trial that GRV does not mean anything. You have to concentrate on the abdominal distension, vomiting, diarrhea, other kind of feeding intolerance.
Great. Thank you. Thank you. There are no questions. Let me check one more time. Oh, we have one question here. I don't know. Okay. So from Zainab, sorry to ask you to repeat it again. I wasn't on my phone when you mentioned it. You said something about protein intake post ICU. Could you please clarify who is specifically we have to target their protein post ICU until 1 year?
Yeah.
So who are
post
yeah.
surgery. يعني in the ERAS post surgery, especially very high risk surgery with long stay. The same like bullet trauma with long stay in the hospital, they benefit from a long-term high protein intake up to 1 year, containing HMB formula, of course.
Mhm, mhm. Hope the answer was clear, Zainab, for you. Anything else? I think this no more. Oh, wow. Okay, we have another one. Thanks a lot for the great lecture, Dr. Khalid. My question is regarding a 22-year-old patient, about 45 kgs. So the mid arm circumference decreased from 20 to 18 centimeters. Home patient with the glioma.
Home care يعني.
Yes.
Glioma?
Yeah, it says glioma.
Glioma means that malignancy in the brain.
Oh.
Cancer brain, yeah.
He is bedridden with progressive disease. He's receiving around 2,000 kcal per day and 80 to 100 grams protein through gastrostomy tube, mixed blenderized feeds plus ONS boluses. Most of the days he's receiving this. However, sometimes many interruptions happen. However, he's still losing muscle. Perhaps refractory cachexia. Any advice, doctor? Will HMB be beneficial to decrease loss? Whether to shift to cyclic feeds or, for example, thanks a lot.
طيب, so HMB, you need to try HMB. You need to try to convince physician to start propranolol, beta blockers, beta 3 blocker, non-selective beta blocker. And you might try oxandrolone for 3 weeks. The most important thing, we have to be sure that he is absorbing the nutrient. And some of the patient has a problem with the GI, they're not absorbing the nutrient due to low HCl, getting BBIs, high doses, whatever. And here you might really supplement parenterally, at least initially, until we'll be out of anabolic resistance. Because now he's in anabolic resistance. We need to really to pick him up and to be out of the anabolic resistance. So getting beta 3 blockers, getting oxandrolone, getting HMB, getting some supplementary protein, even not all total carbohydrate, but just only protein, amino acids, I mean, it might really help.
Dr. Khalid, also, given that she mentioned oncology, I have a question because I get asked this by a lot of patients who are oncology by the families with regards to appetite stimulant, like Dinamogen, for example. They ask, because the patient has low oral feeds. I'm not talking about enteral right now. So ONS. So what are your thoughts regarding the appetite stimulants for oncology
My
cases?
experience with this patient also, they need a time on parenteral nutrition. And some of the patient who are stuck with feeding them orally, if you started them on giving micronutrients, especially supplement micronutrient, their appetite will be changed totally. I can give you a scenario. One lady, she's a wife of my friend, doctor here in the hospital. She was pregnant and she was having hyperemesis gravidarum throughout her whole pregnancy and severe anorexia. I brought her to the hospital, just examined her, gave her oral nutrition supplement, testing her inside the clinic, and I found her fainting. She cannot really drink. She vomited and fainted. And she was in the last trimester of pregnancy. So I admitted to the hospital. We started doing parenteral nutrition, micronutrient mainly. And after 5 days, she went home and she stayed 2 months at home eating all kind of feed. You'll never imagine. Once you replace the micronutrient, she started to eat. حتى even I asked her husband how she's doing. She said she's eating capsa now. So it was really kidding.
And what is the combination of micronutrients you have provided? Was it any specifics, or it's multi?
No, you have I think you have two companies in the market, Baxter and Fresenius, but they are providing an ampoule of micronutrients. They are putting it on the parenteral nutrition. This is just to take this ampoule,
Pre-mixed
plus
ampoule. Okay.
vitamins ampoule and trace element ampoule, and then this is a whole micronutrient.
That's
He can change the life of people, In a lot of patients, I have oncology patient here coming to get TBN for a week, and then they go home, and they go home for 1 year or so doing great. And then again, when they start chemotherapy and they start appetite to come down. So is a message here to replace micronutrient for those categories of patients, they can change their whole life, including appetite and depression and all stuff.
We know that B12, iron, vitamin D, zinc, even zinc plays a big role with the taste, changes. So if it's low, there's evidence, of course. This is very, very interesting, Dr. Khalid.
Yes. The beauty of this trace element is to use it intravenous, because those patients also difficult to absorb it orally. First thing, they are not getting orally well. Second thing, they're not absorbing these kind of micronutrients. Micronutrients need very strong HCl to get absorbed, by the way. Very strong. You need intrinsic factor from parietal cell, which is already atrophied. For whatever you do by oral here, the story is difficult.
Let's see. We have here, thank you, Hiba. She said, thank you, Dr. Khalid, for answering. Good evening. Thank you for the wonderful webinar. I would like to ask you what is your take on blenderized feeds in ICU? As in low-income countries, this is very well dependent on rather than formulas. Ria, very interesting question.
Yeah. But my opinion is we have to start with that, but we need really to calculate from the portion how much protein we are giving, how much carbohydrate we are giving, how much fat, and this is a great burden on the food kitchen to do it, but it is mandatory to be done in this category of food. What is interesting more now is companies start to create whole food formula, not like kind of whey protein or whole food formula, which is really a new now trend in medicine. So we would like to see the outcome from those categories of whole food formula also manufactured by big companies like Nestle and so on and so on.
And do you mean in like a powder form or liquid form? Like,
Liquid form.
interesting. Okay.
Correct. It will
So
appear soon in the market. Maybe and this year you'll find whole food formula, and I believe it is interesting. As the same like now when you go to the gym, formula containing beef protein, and we don't have this luxury before. So why to take milk protein if you have a beef protein there? So you can get beef protein is more healthy actually.
there's a question, Magd, asking, thank you for the lecture, Dr. Khalid. My question is, the resistance exercise is the main stimulus for muscle building, as you mentioned,
Yes.
Dr. Khalid, earlier during your talk. So to minimize muscle loss in the ICU besides proper protein intake. So how to do resistance exercise in the ICU?
Yeah, we have already physiotherapist in intensive care. He's having bars. He is getting a cycle, so the patient can cycle inside ICU on the bed itself. You don't need to have a bed with cycle. Better to have a bed with cycle will be great. But actually, we have a mobile cycle. You get it inside the ICU. A patient can cycle. He can use bar. So there is a lot of things can be done by physiotherapy.
Thank you. Also, one last question before we wrap up this great session. Sarah is asking, do you recommend yogurt recipe for diarrhea in ICU patients instead of using a Banatrol?
What's it? I'm sorry.
Yogurt. So, do you recommend yogurt for
Yogurt,
diarrhea
yeah.
in ICU patients instead of using a Banatrol, given that yogurt has the probiotic?
I can say like there is no evidence that anything will work. We are using Benatrol in our hospital as a fiber, but I'm again. Personally, I don't. I'm against totally the milk products. I'm not getting any milk products, so I don't like to give patient milk. But that's why I'm telling you, if you have a whole food formula, it will be much better than this kind of milk issues. We are learning. Even the companies are learning from our experience. You know, every couple of years, we are meeting with sometimes with the companies, GM in US and like that, and they ask for our opinion and advices. And I love this meeting very much because we give them an idea. Why not to invent that? Why not to create that? And they have a tool to do all this stuff. So before I told them why not to create whole food formula rather than to eat a milk, all kind of milk. And milk is unhealthy. We know that milk is allergic and inflammatory, whatever you go for casein or not casein. But now start they are listening to our recommendation and suggestion. Yeah, I mean.
Okay. Thank
Are
you,
you
Dr.
getting milk? You like milk, Yasmin, or not? You like milk products?
Well, I don't digest milk very well.
That's
To
good.
answer.
That's good. Nobody can
So,
digest, even with lactase, not lactase. Nobody
yeah,
can actually having a good outcome with the milk products, unless certain kind of cheese, which is healthy
so
to this
I
kind.
love yogurt. Yogurt is for the lactic acid aspect, but yes, the milk, the lactose, I noticed, unfortunately, may affect my IBS. So I don't, yeah. So I guess that's why it is common lactose intolerance in the region, GCC in particular. I see it also in the
Yeah, not
clinic.
only the lactose, but the casein itself. Casein itself is very inflammatory, very inflammatory. And I have a lot of patients and friends when they stop the milk, their life has been changed totally.
Thank you, Dr. Khalid, for this really informative, fruitful, interactive, you name it, session. And I hope the attendees, I don't hope, I'm sure it's based on their feedback, they benefited a lot. And I just wish them luck and wish myself luck for the Module 3 exam. Hopefully, we will all do well. Thank you.
Inshallah. And then